My name is Ryan Mosher. I'm a radiation therapist at the Moores Cancer Center, UCSD. I've been there for about 9 years now. And we're going to be talking about patient positioning and fixation. So first, briefly, I'll talk about the clinical workflow that we have at UCSD. Typically, all starts with a consultation. This is where the patient will get to meet with the radiation oncologist and talk about their treatment options and what potential treatment plan the doctor has in mind for that patient. Once the treatment plan has been agreed upon, the next step will be the CT simulation. This is an appointment that gets made about a week after the consultation, and that's where all of the treatment planning process essentially begins. It's a very important part of the process. Once the CT scan is completed, it's sent over to our treatment planning division, which is known as dosimetry. These people sit in front of computers all day long, creating treatment plans for every single patient that we treat. Once these plans are completed, they are sent to our medical physics department, and then the physicists check all the plans to make sure that they're all correct, everything is accurate. Then they're signed off by the radiation oncologist, and then they are ready for treatment. Just a very brief history of CT scanner simulation. The first commercially available CT scanner was created by British engineer Godfrey Hounsfield in 1972 in the UK. By 1973, the United States had installed CT scanners of their own, and by about 1980, about 3 million CT scan examinations had been recorded. About 20 years ago, a CT would take about 30 minutes or more. Now a CT scan can collect images and information in less than 1 to 2 seconds. So you can just see the amount of technological advancement that's taken place just in the last 20 years. The picture on the left is a cross-section of a radiograph. The Hounsfield unit is a relative quantitative measurement of radio density used by radiologists in the interpretation of computed tomography images. HU values for water is going to be 0, and air is going to be minus 1,000. Simply put, dense tissue will appear bright and less dense tissue will appear dark on a CT scan. For instance, air will be very dark and bone will be very bright. So it's just variations of gray. The bone here is going to be completely white. Anytime that there's air, like these are frontal sinuses, there's air in that cavity, so that's completely black. It just helps us differentiate between the different kinds of tissue inside the human body. Now I'll touch on a few of the specifics of the CT scanners that we have at the Moores Cancer Center. The picture on the left looks just like the CT scanner that we use on a daily basis. One thing in particular about the scanner is the slice thickness. We have two options for that. There's 1.25 millimeter slice thickness and 2.5 millimeter slice thickness. Essentially, the thinner the slice, the more accurate you'll be able to see the internal anatomy. It's taking more sections or more pictures of the human body as it goes through the CT scanner, as opposed to 2.5 millimeter slice thickness. The only difference here is that you're going to get more information with the thinner slice thickness, and you'll want that for brain treatments, head and neck treatments, or anytime it's a special procedure or a very high dose to a small area of the body. You're going to want to see more anatomy. That's better for treatment planning. Also, the bore size of this machine is 80 centimeters. That is the size of the hole in the center of the machine, the aperture. 80 centimeters is quite large, so we can fit a lot of large patients through this machine and still be able to properly see all their anatomy. Let's see here. Okay. Then there's also metal artifact reduction, the MAR. So anytime that a patient has metal inside of their body, that will interact with the radiation and create the streaking pattern on the CT scan. So it'll be much harder to see the anatomy. But with the metal artifact reduction, we actually are able to take that completely out of the CT scan and see the anatomy much better. I'll show a picture of that in just a moment. And lastly, on this machine, we also can do 4D motion gating scans. Now, this is not something that we do very often, but it tracks the patient's breathing. So it will track time, essentially. Let's see here. So there should be a picture here of the MAR. So this is a patient that had double hip replacement. So they're going to have a lot of metal in their hips. And as you can tell, you really can't see the anatomy very well because of the metal. Once you place, use the software to take away the streaking, you use the MAR. This is a really good CT scan. Now you can see the anatomy clearly. It takes away completely this streaking. So it's a really nice option to have when you're making treatment plans. There's several forms that we use, written directives, in order to get CT scans completed for documentation purposes. And the one that I'm going to be talking about here is the physician order form. Physician's orders provide directions to the CT simulation team regarding medications, procedures, treatments, therapy, diagnostic tests, or laboratory tests. The order form must contain accurate and specific information for patient simulation. The order form must also be signed off by the attending MD prior to simulation. Show an exact copy of this one right here. So this is just a blank copy that I can interact with. I'm going to want the patient's name, date of birth, whoever the primary MD was as well. All of these have drop downs on them. Excuse me for this very quick glitch. I just want to be able to show all of the options that we have with these forms. Possible. The computer will comply, which it doesn't seem to be at this time. That's okay. So unfortunately, I wasn't able to pull up that document to interact with it directly, but any box that says select will have a series of drop-down options for you. The patient, if the treatment's going to be palliative or curative, that's always good to know. The sim date, what kind of imaging will be used during treatment, any modification devices, the amount of monitor units. Let's see, cardiac device. If a patient has a pacemaker, this is great information to know ahead of time before the CT scan. Every patient needs to be consented, and that consent must be obtained before the CT scan takes place. If it's a pediatric patient, if there's any anesthesia, pregnancy tests, it's very important as well. Previous radiation treatment, it's good to know a patient has been treated in that same area before. Then there's also the type of CT scan that's taking place, what part of the body, modality. This is just like if it's going to be IMRT or conformal or some kind of rapid arc treatment, what kind of radiation treatment it's going to be. Scans, full or empty bladder, enema prep. The enema prep is something they'll take beforehand in order to get the rectum to be completely empty. And this typically refers to prostate patients. So for prostate patients, we ask that they come in with a full bladder and an empty rectum. And the reason for this, it's very important that they have a full bladder and an empty rectum, because so this is the prostate here, and this is where the radiation dose is going to be delivered. This is the bladder, and you want to have the bladder to be quite full so that it will push the small bowel, which is here. It's going to push it up and away from the field of radiation, which is beneficial because the patient will get fewer side effects. This here is the rectum. You can tell it's empty, quite small. That's desirable as well. The more full it is, it's going to expand and it might get a little bit of radiation dose. So keeping the radiation dose off of the rectum and small bowel is what we're trying to do here, while we're delivering all the dose to the prostate. Slideshow again. Slide. Okay. Yeah, so definitely important. Every patient for prostate cancer that comes in has a full bladder and an empty rectum. They should be ready to go for that CT scan. Over here, the doctor can tell us how many days they want for planning purposes. 10 business days or 2 weeks is our standard for most treatments, unless it's a special procedure, which is a much higher dose to a smaller area in just 5 fractions or 5 treatments or less. Then it will be probably 5 business days. Let's see, the kind of frequency. Will the treatment be every day? Will it be every other day? This is good to know ahead of time. Let's see here. Scanning parameters. The doctor can tell us what part of the body they want scanned, so they can pick head through pelvis, and then the radiation therapist will scan that part of the body. They also have a checkbox here for paging the doctor to come to the CT scan ahead of time. Sometimes the doctors want to come and draw on the patient or place some kind of marker on the patient. That's when they would check this box, and we would page them to come over and help us facilitate any of these checkboxes here before we start the CT scan. Patient setup. What kind of orientation does the doctor want us to have the patient in? You can get very specific for how the patient is set up right here. Wiring the scar, this is important. Sometimes doctors want to know exactly where the tumors are, if it's like on the outside of the body. If there's any bolus involved, we have different size bolus, like 0.5 centimeter, 1 centimeter thickness. Bolus just helps bring the radiation dose a little bit closer to the skin surface. Let's see what else we have here. Also, if it's a special treatment procedure, for any kind of treatment, actually, it's good to know if it's concurrent chemo. If the chemo is going to start the same day as the radiation treatment, we have to know that ahead of time so we can schedule it accordingly. Protocol, this just means if the patient is on any kind of clinical trial. If it's a retreatment, that's good to know as well. Image fusion. So this is important when if a patient has multiple forms of imaging, say they have a CT scan, a PET CT scan, and then also an MRI, we have to fuse all those images together for treatment planning purposes. So the doctors will put what other kinds of images they want to be fused together for the treatment. We also do electron treatments. These are typically superficial or skin treatments most of the time, but part of the body where the simulation is going to be taking place. These simulations can be actually done in the treatment room as well. What kind of shielding is going to take place? There's a place for notes, anything in particular. We do brachytherapy as well at UCSD. And at the very bottom of the sim form, or the physician's order form, is just a note section where the doctor can write in anything that they want that's specific to that patient's setup. The note section comes in very helpful. This is just to help facilitate communication between the radiation therapists and the doctors, so that everyone is clearly understanding what needs to be done for each patient. Then there's immobilization and reproducibility. This can be translated into unable to move. You want the patient to be holding still for the entire treatment. As well, for the simulation, you want them in the exact same position, so they cannot be moving around at all. Radiation therapy is designed very precisely to treat exactly the right area, so it is important to keep that part of the body as still as possible during treatment. Immobilization devices provide the added benefit of ensuring reproducibility on a daily basis and also significantly reduce errors in patient positioning. Another very important aspect of reproducibility is table rigidity. Both the simulation and treatment tables are very hard and very flat. This is done purposely to ensure that the patient position relative to the simulation table will be the same for treatment. So we want each treatment or each setup to be relatively identical. That way we're ensuring that we're treating the correct part of the body each time. We want the patient to be lined up exactly the same for every treatment. And the tables being very flat and hard helps facilitate that. There's a few potential for errors during simulation as well. Incorrect patient identification. This is very important because if you identify the incorrect patient for a CT scan, you've essentially given a stranger a radiation dose that did not need to be given at all. Also, if this patient's information is passed down to the treatment planning phase, there's a chance that a plan will be created for the incorrect patient. So that's something to keep in mind when you're doing a CT scan. Definitely identifying the correct patient. Improper fixation documentation. So everything that goes into a simulation needs to be documented correctly and accurately. Scanning the incorrect body part. This is a major issue as well. If the doctor wants you to scan from the head to the pelvis, but you end up scanning the entire body, you've effectively given that patient more radiation dose than necessary. And then this brings up the issue of ALARA, which stands for as low as reasonably achievable. Essentially, if you don't have to give any radiation dose to the patient, you shouldn't be doing that. Extra dose is just completely unnecessary. It should be avoided at all costs. Incorrect preparation or positioning. For instance, the prostate preparation. If a prostate patient comes in for radiation treatment and their bladder is not full enough, it's going to be very hard to make a treatment plan based off of that CT scan because the bladder is not effectively pushing the small bowel away from the radiation treatment. Or if they have a full rectum, they're not prepared for their CT scan, you can't make a proper radiation treatment plan with a full rectum or gas in the rectum. So it's always best to follow the physician's orders directly and then making sure that you're documenting that information correctly. Mobilization devices. Mobilization device is any device that helps to establish and maintain the patient in a fixed, well-defined position over the course of an entire treatment. We have a few devices that we can help with that. Velcro straps. These are to help the patient keep their arms on the treatment table if they can't do so themselves. These rings patients can hold on to. It just gives their hands something to hold on to if we're treating their pelvis. Obviously, we don't want to be treating their hands and arms as well. So the ring is something for them to hold on to. We use rubber bands. Those will go around the patient's feet. That will keep their feet and legs in the same position. Then we also use foam cushions and wedges. These are mainly for patient comfort, or if we're trying to achieve a certain position, we might put one of these devices underneath a patient's back to kind of elevate them more or something, but they're mainly for comfort, also reproducibility. We also treat a lot of head and neck patients. All of these patients lay on top of what's called an S-frame. This is a board that goes on top of the table so that the mask can be snapped down to it. It's used primarily for head and neck cancers. There are headrests that come in different shapes to accommodate each patient's unique setup for these head and neck cancers. You can see right here, there's a custom headrest for this patient. Masks are thermoplastic, which means they become pliable or moldable at a certain temperature and solidify upon cooling. They're meant to hold the patient in the exact same position for every treatment. So we'll put the masks in this oven. It kind of heats them up, and then after about 5 minutes, they're ready to be placed on the patient. And then once they cool down, they'll hold that position forever. That's the shape that they're going to be in. So, for instance, this patient here had this exact same mask, I think 25 treatments in a row. It held the patient in the correct spot every time for treatment. So, a very important treatment device. As I had mentioned earlier, the head cushions, we have a few different kinds here. These ones are called Timo head cushions. They're soft, and they do come in different shapes, different sizes. Then we have here this custom head cushion. These will go on top of either the TMOs or the Silverman headrests, and these are pliable as well. You get water on them, and then you mold them to the patient's head, and then wait a few minutes, and once they harden, this is the shape that they're going to be in for the rest of the treatment for the patient. So it's for patient comfort mainly. So if you were to treat a patient with these every day for 25 treatments, it'd be quite uncomfortable. This just helps for comfort and as well as reproducibility. We also have prone pillows, which is this cushion right here. This is mainly for scalp and back treatments so that the patient is still in a comfortable position so that we can get to their scalp or their back. We use a lot of backlogs. That's this device here, and this one around this child here. We suck the air out of these bags, and then they hold their shape just like this. This patient, the head would have gone here, arms go right here on the sides, and then they'd be holding on to these two handlebars. And this is what the wing board would actually look like without the backlog on top of it. Go ahead. Feel free to interrupt at any time. Okay, let's move on. We also treat a lot of breast cancer cases. This is the Breastboard that we have at UCSD. This helps facilitate having a patient's arms be over their head for tangential beams. With this board, we have the ability to elevate and also lay flat. A lot of moving parts on this board. Storage and care of backlogs. Backlogs should be stored in individual compartments with patient names hidden from view. As you can see, all of our backlogs here, you can't see the names. They should all be hidden from view, so other patients, when they come in, they can't look over and just see who's being treated. It keeps things anonymous. See, after a treatment course is complete, all backlogs are returned to CT simulation and are cleaned with bleach and put back into rotation to be used for new patients. So all of these are reused unless they have a hole in them and they can't keep their rigidity, then they're thrown away. So here's just a quick overview of the workflow where I work. So if they're coming in for a CT scan, we're going to identify the patient and explain the procedure to them, what's going to take place. We'll identify the patient with their name, their date of birth. If they have a photo on them, we'll use photo ID, and also treatment site. So we'll always ask the patient what site we're going to be scanning that day. That helps verify exactly who we're dealing with. Then we'll get the patient set up correctly for treatment. We'll place any kind of fiducial markers or BBs on them, which you can see here. These are good for planning.
Yeah, Ryan,
Yes.
Before keep going on the workflow, because this is another part in the lecture, I would like just to take a little bit 2-minute or 1-minute pause to ask everybody if there is any questions. في أي أسئلة?
Yes. Hello.
Hello.
Oh, I'm Contra from Morocco, and I'm asking about the backlogs. How many times have we used?
I would say they should be good for multiple years. Maybe every 2 to 3 years we have to get new ones, but they last quite a long time.
Yeah.
Wow, great. Yeah, because we had a discussion at our center this morning, and we've been like asking if it's personalized for each patient, or if we should like work with them until it's done, you know? Yeah. So.
Yeah, they should be only in one position. Each backlog should only have one position for the entire course of their treatment. If it starts to leak or something, then that backlog should be thrown away. But ideally, yeah, the backlog should only be set or sealed one time per patient per treatment.
Okay, thank you.
You're welcome.
I have a question myself, Ryan. If we don't have an oven to put the masks in and using the water pool, what is the optimum degree of the water in order just not to ruin the mask itself, and put the degree on the optimum that let them be able to be?
Sure. You know, that's a great question. Before we had this oven, we had
Yeah.
a water bath. So exactly what you're saying, we would just.
Ovens, till now.
Oh,
So
okay. Yeah. And we have since gotten rid of our water baths. I do not remember the exact temperature.
okay.
I could look that up and email it to you if you would like.
Yes, please. Because I think everybody شباب أنا سألته لو إحنا ما عندناش إحنا لسه بنستخدم الووتر بول، فسألته إيه الأوبتيمم ديجري أو درجة الحرارة المناسبة إن إحنا نحطه فيه، لأنه this is a frequent question ناس كتير، فريان هيقول لنا ويبعتها لي by email. Thank you, Ryan.
You're welcome.
Your voice is not clear. Can you write it down on the chat room, please?
What I said that. What is this? I could understand. Yeah. I'll answer if ready. So I think he's referring to the shrinking of the mask. He's correct. This does happen. So once you put the mask on the patient and it's cooling down and molding or hardening, it's going to continue to shrink. So you want to leave it on the patient for long enough that the shrinking process is completed. Now, if you don't have enough time to do that, what a lot of places will do is they'll put these pieces of thin plastic underneath the patient. They're called shims, and it just elevates the body a little bit and allows for a little bit more room inside the mask because of the shrinkage. So yes, you can build up the mask a little bit so that you can avoid that. So it's not too tight when it comes to treatment. Or you can leave the patient in it a little bit longer so everything cools down. Because even after the scan is done, if the mask isn't cool yet, it'll still continue to shrink a little bit and be very, very tight.
Okay.
Not sure if that answers the question.
Last question I have it now. Could you please explain again what the pore size is?
The bore size. The bore size is just the size of the hole in the center of the CT scanner.
Mm-hmm.
It's this here. The distance from here to here. That's what that is.
Yep.
And based off of that size is the size of the patients that you can fit through your CT scanner.
Yeah, and it's obviously wider when we order a CT scan rather than radiological CT. It's much more wider.
Yes, that's correct.
Yeah. Okay, we can continue.
Can I ask a question, please?
Sure.
Yeah, the breastboard you said has different angles. Which angle for which patient?
The breastboard. Okay. Yeah. Good question. So, for instance, here in this picture where it's elevated, this is just going to be for a regular tangential breast patient. So just two fields coming in. It's elevated a little bit more because of the angle that we're treating on the breast. And then it's going to be flat, or right here like it is, for mono-iso, or three-field breasts. When you're trying to treat the supraclav, you'll have a more en face, or where the gantry is directly over the patient and it's leveled. This will help facilitate three-field breast treatments when it's flat, and we have it elevated for just tangential treatments.
Thank you.
You're welcome. Any other questions? Okay. So I think I left off with getting the patient set up correctly for the CT scan. Then we're going to draw on them or place any fiducial marks, which are BBs, which are shown here. And we take photos of the setup, we document everything, we perform the CT scan. Once the CT scan is complete, we give the patient some tattoos. These are permanent tattoos. They're very, very small. You put a drop of ink on the patient's skin. You just poke the skin slightly and they have a permanent tattoo. Looks just like this. Very, very small. Looks like the size of a freckle. Let's see here. And those are what the therapists are going to use each day to set the treatment or set the patient up for treatment, looking for those tattoos. So this is just a workflow of what takes place once the CT scan is completed. We send it to this computer that helps us pick an ISO center. Based off of that CT scan, once we have that information saved, we export the CT scan to our dosimetry department. These people sit in front of computers all day making radiation treatment plans. Then Once they've picked up the treatment plan and started working on it, the whole process then begins. And then they can spend all of their time focused on just that radiation treatment plan. I've also got some examples of simulation forms. Let's see if I can get a real document here. Okay, so here's an example of a blank, completely blank sim form. You'll want the site in there, what part of the body we're treating, patient's name, date of birth, the MD involved, patient setup, anything specific to the patient setup, what position they're in, what kind of headrest, what kind of mask was used, was there a wing board or chest board, back lock, were their feet bound, the knees, did they have any cushion under their knees, what position were the arms in, the sim date, the start date of treatment. Let's see here, this one's not working so well with me. So this is an actual patient sim form that I took the patient information out of. Slideshow here. Okay. And for this individual, he had a little bit different setup. His arms were up, holding only the left handle, and there was a blue triangle under the right elbow. So this kind of information is very important for the therapists that are setting up the patient to know. So that way they can reproduce the setup exactly. So being very detailed and accurate with your descriptions are important for the entire team. Here we have the next part of the form, which is all the photos, the documentation of the actual setup. Patients holding on to the left handle. As stated, there is a vac lock, and you can't really see it, but there's another device helping to hold up the arm. Actually be on this side here. You can kind of see it. There's a cushion. There's a cushion under the patient's knees. So you really want to take good pictures of the entire patient setup so that we have something to refer to if there's any question in how the patient should be set up every day for treatment. You can also see the fiducial markers here a little bit. Sorry, the clarity is not very good, but there was one on the chest, one on this side, and there's also one on the other side as well, which you can't see pictured here. More documentation. How many CT slices were taken? We have to document all the information about the radiation from the CT scan. This is essentially the dose from the CT scan. We're required to document all that information. Down in the notes section, this is the doctor's initials. This is the kind of treatment the patient is to receive. The amount of delay between CT scan and first treatment is 10 business days so that the treatment plan can be completed. It's going to be chemo with radiation, and here's the start date. 33 treatments total. There's also image fusion. This is where the doctor can request to have other images that were taken of the patient to be fused for this patient's treatment planning session. So they might have an MRI or a PET scan or something that they want to take into account for the radiation treatment plan. Let's see. Where any device, we're going to tell the therapist where they can find it. This is one of the machines, the Torrey Pine machine. There's also time requests. The patient can have a time request. This just shows the kind of devices that we had. We had a vac lock that we had used. If any contrast is given to the patient, it's marked down here. This patient did not have a contrast simulation. And the last part of the sim form is just this part here. This is kind of the same for every doctor. It's just stating that the simulation is necessary for a radiation treatment plan, and that everything has been overseen by the doctor prior to the CT scan taking place. There are some ways to make documentation mistakes. This can definitely happen. Say a patient was supposed to have a table pad and that was not documented for the radiation treatment, then a patient could be treated every day without a table pad that was supposed to have been there. And what that means is that the dose might not be the same delivered to the patient. So every kind of treatment device that was there for the CT scan must be present for the treatment as well. You want everything to be exactly the same. If the incorrect bolus size was used or documented, So they come in different thicknesses, the bolus does. And if the incorrect size is used for a patient's treatment, that's effectively mistreating the patient. So you want to be very particular and accurate with your documentation. Sending the incorrect patient to dosimetry. So you want to be 100% certain that the information you're sending to your dosimetry department is accurate and that you have the correct patient documented. You don't want to make a treatment plan for a patient that doesn't need it, essentially. Documenting incorrect headrest size. Just once again, any device that goes into the CT simulation has to be documented correctly so that the patient, when it comes to treatment, is set up correctly and treated correctly every single day. In conclusion, attention to detail during the CT simulation is of utmost importance because this, number one, translates into better and more accurate treatment planning and calculation, and it also results in a better and more reproducible setup on the treatment machine. The main takeaway from this presentation is to immobilize the patient correctly, document it, and make sure that everything is accurate because we're trying to achieve a reproducible setup every single day that that patient is on treatment. That concludes the presentation, and I'm open for questions.
Thank you, dear Ryan. It was really comprehensive, fruitful presentation. And now I will open the floor for the colleagues to ask questions, or feel free to write it down on the chat room and I will deliver it to Ryan.
Sounds good.
I have a question from Winston. He is asking about the tattoo points because he said that he used to tattoo the patients on the 2D era. Yes. They are preparing to have the 3D. So he is asking about what we are going to tattoo. We tattoo the laser, we tattoo the intersections, what tattoo is.
Sure. The tattoo is to get you as close as possible to the ISO center, or the point where the doctor is going to be putting all of the radiation dose. So most of the time, how it works in my department is that we will tattoo the patient in the general vicinity of where the treatment's going to be. And then once we send that information to our dosimetry department, once they pull it into their computers, they will then pick the exact ISO center, which will be pretty close to the tattoos, but we'll get shifts typically. Shifts on day one from the tattoo to exactly where our ISO center is going to be. This is pretty typical for us.
I will translate it in Arabic because this is a very important point.
Sure.
And all friends, the 2D concepts. المفروض ان احنا لما بنعمل الليزر الاينمنت ده بيدينا المظبوطه كده نعمل تاتو upon that. لما بنترانسفير الداتا دي للفيزيكس هو بيبقى شايف بال 3D الايزو المظبوط، فبيريفير من البوينت دي اسمها ريفرنس بوينت، بنسميها ريفرنس بوينت. نقطه التاتو اسمها ريفرنس بوينت، بنريفير ليها the exact ISO اللي بعد كده هنعمل shift للتيبل during the treatment مع أول session. Okay, I used to say that this point named reference point. It's not the true tattoo, the true ISO. The ISO is delivered later, but this is one of the reference point which is very close, or the approximate ISO that the physics is going to calculate upon.
Correct. Yes. Yep.
Okay, excuse me.
Yes, sure. Go on.
I want to ask a question.
Yeah.
About tattooing during simulation. It a little bit will be painful.
I think tattoo different.
So when you treated, you have to shift into a different point. Also, again, tattooing, this will be two different points.
We will not tattoo again.
Tattoos is difficult in black patients.
Also, it's painful. I feel patient in hurting from tattooing.
No, it's not that hurt. Just smile and say, you will find just a little bit kick and that's it. What do you think, Ryan?
Yeah, it's not very painful. All that you do is you place a drop of ink on the skin, and then you just kind of poke the skin a little bit. Yeah, it's like a bee. If you've ever been stung by a bee sting hurts much worse than a tattoo. What else? Was there any other question on top of that?
Regarding dark skin
Dark
people.
skin. Yes, we have a lot of African Americans we treat, and we still use black ink, and we're able to find the tattoos pretty well. If there's any question, you always just take a picture of it, of where it was located on the body, and then you use that picture on day one of treatment to find it again if it's difficult to find.
Okay, I have many questions regarding the adjustment of the breastboard.
Okay.
I need the picture again, and when to make it flat, and when to use different angulation. And you can, and I will collect the question from our colleagues. So we can answer, Ryan, now the breast hold angles for everybody.
Yes. So where I work, we only use 2 different angles. One is going to be at this elevated position here, which is 12.5 degrees. And then the other one is just completely flat. So for the elevated, we're going to be just tangential beams, just 2 fields, one from the top, one from the bottom, kind of the side of the patient. And then when it's flat, it's going to be mono-iso, and we're going to include the superclav here. So this is a 3-field radiation treatment setup, and this one's just a 2-field radiation treatment setup. So that's the main difference.
So if there is a 3-field, you mean supraclav and 2 tangential field with 1 mono center?
That is correct. Yes.
Yeah, in this case, we put it flat.
You do, okay.
So why that?
Why is it flat? Oh,
yeah.
I think the main reason
I used to have the mono 3-field, and I just keep it 10 degrees, but not flat.
But not flat.
20.
You know, it might vary from facility to facility.
Okay.
I think one of the reasons that it's flat for 3-field patients is that so that the machine is more en face, or there's not as much of an angle when you're going to be treating the patient, superclav. Okay. And also beam divergence, so you can, if the patient is laying flat, they're a little bit further from the machine and they can get more radiation beams to the patient.
Okay. So Zahra was asking about the previous slide, the patient with tattoo. There is a breast patient with a tattoo. Can we go breast patient?
Breast patient with tattoo. This one here?
Oh, keep on. Keep going.
ما هاي الصورة. Yes.
This one? Okay.
CI breast. CI breast. Prone position. Prone position.
Prone. That's yes. A different kind of breastboard. I did not.
Yes. هاي الحالة breastboard. اللي prone position في حالة CI breast.
Okay.
الماركرز بس ممكن الصورة دي تشوفها حتى هوني.
Do we have a tattoo in prone position? Previous pictures?
Do we have a what?
A patient in prone position with tattoo?
No, it's just
slide number.
Okay, let's see if there's any pictures. I did not put that in the presentation, but here is a picture of what that would look like. Right here.
Yeah, breast. Prone position.
Yes, this is the prone position. This is
prone
similar.
Position, yes.
Yeah.
هاي بدون breastboard.
لا ما فيهاش breastboard. This is a very special board. The board for prone position. احنا بنشتريه مخصوص. ملوش أي علاقة بالبريست هولد supine position. ده حاجة لوحدها. ده حاجة لوحدها تماما. يعني السوباين ما ينفعش أقلبه برون خالص. ده device.
Yes. هاي في حالة البريست بورد السوباين. ثلاثة الجهات اللخخ يعني left breast.
فهمتك. She asked about the tattoo.
يعني موقع الليزرات.
ده out of our scope now, Zahra, but I will deliver it to Ryan. She asked about the laser dissection and the tattoo marks, if any, in prone case. How can we identify it?
Yes. Okay, so the prone patient would still be getting tattoos as well. They'd be getting one on the back and then also
Yes.
one on the side as well. So they'd be getting 2 tattoos.
Lateral axillary line, I think, Ryan?
Yes,
Lateral,
correct.
lateral axillary line, yeah. And it is not indicated if there is any lymph node treatment. You can use the prone position only if you are going to radiate the breast tissue tangentially.
Yes, that's correct. That's what it's used for mainly.
Yeah. It's not for the case that indicated for supraclav. You cannot do it by prone position.
I think it is quite a bit more difficult. That's correct. Yeah.
But you cannot join the supraclav on the same setup and the same positioning with the prone position.
That's correct. Yeah, for prone breast patients, I don't think we treat any supraclavs that way.
No. Yeah. The last question I have regarding the TB, total body irradiation.
Okay.
This is a big story. So they ask about how can we do the total body irradiation. I think this has to be another separate lecture.
Yeah.
Or we can send a reference by email to everybody.
We certainly could.
Or if you have already slides for TBI, we can share it together.
As of right now, I do not have any. Yeah, that I'd have to. You could email me information, then I could email you guys back what information I would have on TBIs.
They ask many questions regarding the fixation tool for TBI. There is no fixation for TBI. It depends on, because I used to practice the total body radiation.
Yes.
It's plenty of ways to low dose or moving table, fixing table. So
yes. Yep, you're correct.
Many types, yeah.
Yeah.
So what we have again, they asked about the pediatric. Of course, pediatric simulation have another issue regarding they are small in everything. They have special masks, special fixation tools. We cannot use the adult fixation tool for beads. Am I right?
Actually, for take for instance our head and neck masks.
Yeah.
They're kind of one size fits all, so you can use them for children as well. They'll just take up much less of the mask.
I used to work on pediatric cancer center for 12 years, and we have our own masks with the small sizes. So.
Oh, really? Wow.
Yeah.
Yeah, I'm sure they make them. Yeah, we're at UCSD. We just use one size, but if you can find children's sizes, that's very helpful.
Yeah. Okay. So last question, which is important, and many asked it. Should we make another new tattoo after doing the shaft in the first setup regarding the real ISO center or true ISO? Should we tattoo at this point when we shift to the new and real ISO? Do you tattoo it or just mark it and say it's 2 centimeters below the reference point and that's it?
What we use is something called tegaderms.
What is it?
And these are, so what we do not give second tattoos. So we'll get shifts from the tattoo to the isocenter, and then we'll put like a crosshair, or we'll draw on the patient exactly where that mark is, and we'll put a sticker over it. And that sticker stays on there for the course of their treatment.
Yeah, I do the same. Okay. I don't tattoo the new ISO. I just mark and ask the therapist to keep marking every day when he deliver him the session. Just confirm the mark.
Yes.
every day.
Yep.
And put a plaster or something in order. If he had a shower or something like that, it doesn't. I don't do another tattoo for the real ISO.
That's the same thing we do. That's yeah.
So we have a question for the fusion image.
Okay.
MRI, the factors to compare between them.
Sure.
Yeah, a question regarding the fusion image. Yeah.
Okay, I can just talk in a little bit more detail about the image fusion.
Yeah.
So every patient that comes in for radiation treatment has to have a CT scan, unless they're an electron patient. If the patient wants, or the doctor wants to see internal anatomy, they have to have a CT scan. Oftentimes, patients will need other kinds of scans as well, and this just helps the doctors see more anatomy. So a lot of times for an SRS case, or we're treating a patient's brain, the doctor will request an MRI, which is a different type of scan that shows soft tissue very, very well. And they'll take that MRI and fuse it with the CT scan or PET scan as well, sometimes 3 scans, and fuse them all together. And then based off of that image, they'll create the radiation treatment plan. It's just the more imaging you have, the better.
More imaging. So we can fuse the MRI, PET CT, whatever we have, in order just to make an idea from collectively all the imaging together.
That's correct. It takes all of the imaging and puts it into one image.
Yeah. Okay. And do you put the patient during simulation with the same position of the MRI or CT, or this is a universal agreement regarding the positioning itself in order to make the fusion easy?
Well, I'm not quite understanding the question.
I mean, when the patients go before the surgery to make, let's say, MRI department to do the CT simulator, and after that I will fuse them together. The positioning is different. So how can you deal?
Yes, that's a good question. There is computer software. One of them is called MIM, M-I-M, M-I-M, and I forget what it stands for, but that software specializes in infusing images that weren't in the exact same position.
Yeah, I work on it. It's really marvelous.
Yes, yeah.
MIM,
So
yeah.
That's what we use is MIM, yeah.
Okay, we have a question from Rashid, our colleague from Sudan, asking about the obese patients with pendulous breast.
Yes.
How can we overcome this problem during the simulator?
Well, typically any patient that is obese and has very pendulous breasts will be scanned on a prone board. That's the best way to scan a patient that has very large breasts, because then you can allow the breast to hang as much as needed, because you can't fight gravity. So you have to have a breastboard in order to treat an obese breast cancer patient.
Another thing, if you don't have this board, or for instance, this patient is indicated for supraclav, so it will be a problem for field matching. So if I'm going to treat her in supine position, should I go for custom-made fixation orphet, or?
That's a good question. I would say some patients where they actually absolutely have to treat the supraclav, the doctor will just request that we tape the breast in the same position each day. So we're using tape then to kind of keep the breast in the right position, if they have to be. If they have to be prone, though, that takes away all the guesswork. But if in the case that they have to be supine and they're obese, we'll use tape, a lot of tape, to keep the breast in the same position each day.
Tape? What do you mean by tape? Tape?
Tape is actually like, sticky tape, so that we can move the breast into the same position that it was scanned in, because it can move around on a daily basis.
And you don't use mask?
No, we don't use masks for breast patients.
Okay, let me translate it. سؤالك عن البندulous breast أو الhuge breast بيعمل taping، يعني بيلزق بالبلاستر البريست، بيشده ويخليه same position every day، بس هما مش بيعملوا ماسك، مش بيعملوا breast mask. For me أنا بعمل breast mask، يعني in Egypt we do breast mask، but نعرف إنه it will carry out some acute reaction on the skin sometimes. in Ryan Center they are taping بيعملوا plaster عشان يثبتوا breast in the same position. Okay. Okay. I think we finished. Last question regarding the. No, we answered it all. Okay. I will keep collecting the questions even to my email. I will share my email for everybody, and we can always contact Ryan even after the. Okay.
Absolutely. Yeah.
Yes, sure.
Why you're not using breast bra for bundulus breast in supine position? We use it in our center.
What was the question again?
In bundulus breast, large breast, if we treat it in supine position, we use a special bra to for fixation.
Yeah, there's been a few doctors in my clinic that have used bras as well. It's rare, but I think the bra is fine. As long as there's no metal in it and the bra is stable, it can definitely keep the breast in the same position every day. There's also something called netting. It's this material that wraps around the patient. It kind of keeps everything stable.
Mm-hmm.
That definitely helps us facilitate keeping the breast tissue in the same position as well. So we use tape, we use netting, and then sometimes the doctor will request that a bra is used so long as there is no metal in it. So those three things definitely help keep large-breasted patients in the correct position.
Very good. Okay. So it was very interesting, really, presentation, and the discussion was more interesting from everybody. I'm very happy to have this interactive questions and discussion. And I would like to thank you so much, Ryan, for today. And thank you, everybody. I encourage you all to keep sending the questions for me or Ryan directly, and we will try our best to answer you all. Thank you all. Thank you, Ryan. Bye-bye.
Thank you very much. Bye-bye.
Thank you.